So to start with, I want to thank the organizers for inviting me here. Thank you, Harry, and thank you, Mark Lamaire. I will talk about epicardial AF ablation, but first I will review with you and walk you through the main messages we have from transvenous catheter ablation, so that we can get a motivation why we have started with this surgical approach. I think the landmark is actually this paper from 1980. It's many, many years ago. Cox showing that just by isolating the left atrium, we have the whole heart going in sinus rhythm, while the left atrium still is in atrial fibrillation. And the next landmark is, of course, Heisagar's work with the PV isolation being the cornerstone of all AF ablations. So the randomized trials performed with the transvenous catheter ablations, there are 10, I think. As we see here, most of them have been in patients with paroxysmal AF. There are only 2 on persistent, and only 2 in whom it was the first line of treatment. And as we can see, the success rate, or the freedom from AF after 1 year of follow-up, has ranged between 60 and 80%. Now that is, we know, but I think it's very interesting to see, if you look at the blue bars, which are the control groups, and I am a bit astonished that the variation is so different between the patients in the control group, because they were the ones that actually had failed antiarrhythmic therapy, and most of them had tried 2 or more antiarrhythmic drugs. So I think it emphasizes the importance that if you're going to evaluate a treatment, you must have a control group, otherwise you do not know the benefit of the new treatment. So what about AF ablation, transvenous AF ablation? We know that the long-term follow-ups, 5 years, is not as good as the initial efficacy that is published, as we can see in these 4 studies. And most of these AF recurrences are related to the reconnection of the pulmonary veins. I think it's one also important thing to emphasize is that as opposed to many other trials, AF ablation trials have not the indication for the treatment, but the AF or not AF at follow-up as the primary endpoint. So all measure actually if there has been an episode of AF lasting longer than 30 seconds instead of looking at quality of life or symptoms. So this has been the primary endpoint for a very long time, and I think it's time to change it if we're going to evaluate treatment. I think for methodological purposes we could still use it, but to evaluate the clinical efficacy we'll have to change primary endpoint. What about paroxysmal and persistent? We also know about that. The long-term efficacy rate is, and the absolute result or efficacy for persistent atrial fibrillation is not as good as those for the paroxysmal. This is a meta-analysis including 19 studies, 2 of which were randomized over 6,000 patients. And these slides also show that the efficacy rates for the long-standing persistent AF, this is a 5-year follow-up of these patients, is also not as good as for the paroxysmal and as the other persistent, with an efficacy of only 20% after 5 years, but better, it seems better if you do multiple procedure or additional kind of procedures. And finally, this meta-analysis of randomized control trials in patients with paroxysmal AF and persistent AF. If you add linear lesions, it indicated that in only persistent AF, this was of benefit for the patient population. But again, these meta-analyses were not randomized trials with regard to pulmonary vein isolation versus PVI plus linear lesions. They were randomized for other reasons, for example, for comparison of drugs. So if we look at the recommendations and the guidelines that has published, this is the one from the catheter ablation recommendations published in 2012. We can read that if additional linear lesions are applied, we should assess for line completeness. And if patients have long-standing persistent, we should consider extensive ablation, linear and complex fractionated electrograms. So these are the ones that were recommended to perform. Now, if we look at the systematic review and meta-analysis of patients undergoing ablation with persistent AF, we can see that from the 46 studies, over 3,800 patients, AF ablation was superior to antiarrhythmic drugs as expected. The outcomes was better if PVs were encircled versus if only lines or café ablation was performed. Electrical isolation was better than only anatomic encircling, and left atrial lines was superior to performing café ablation. What they could not demonstrate was that the results were not improved by more extensive linear lesions or by atrial ablation. So the conclusion from this study was that the most efficacious strategy is likely pulmonary vein isolation plus some limited linear ablation in the left atrium. And finally, the last study, which I suspect it's not published, I didn't find it yet, but it was presented at the EC Congress last year, the STAR AF2 trial, randomizing patients between pulmonary vein isolation, plus lines or plus café. 48 experienced centers, no difference in outcome, 50% were free from atrial fibrillation. With regard to safety, the procedures took 1 hour longer time and 12 minutes longer fluoroscopy time. So this recommendation made in the guidelines, I think will have to change, proven by the publication from Wien about the café being effective and about the linear lesion to be effective as an additive, at least when you use it endocardially. So I guess that instead of see what happens strategy, which I think has been the case in many instances if we do the transvenous ablation, I think this is the reason why many centers and labs have started with the epicardial AF ablations, which has been off-pump, minimally invasive or thoracoscopic. The lesion sets have started off with pulmonary vein isolation, adding linear lesions. In some centers have used box lesions or only roof lines or bottom lines. It has also sometimes included vagal denervation and left atrial appendage isolation, and now lately also hybrid procedures. So I think I'll summarize this kind of technique and present some of the results. Edgerton was one of the pioneers. This is a study published from 2010, and it included 52 patients with paroxysmal AF. His technique included pulmonary vein isolation, autonomic denervation, and exclusion of the left atrial appendage. He followed the patients for 1 year, and with 24-hour halters and a 14-day event recorder. The efficacy rate was 81% at 12 months, and freedom from atrial fibrillation and atrial tachycardia. Not all patients were off antiarrhythmic drug, 33 of 37. So how many then patients were free from symptoms? That was not corresponding to the freedom from AF. It was 64% at 12 months. Again, this was non-randomized, so we don't know what the improvement would have been if we had had a control group. This is our first study. It's a comparison. It's also a pulmonary vein isolation using the Epicardial MACE procedure. 65% of the patients had paroxysmal AF, 14% persistent, and 21% permanent. And about half had failed previous AF ablation procedures. We did a bilateral PV isolation, vagal denervation, and confirmed the PVI using intraoperative mapping technique. Quality of life was normalized, as we can see here. Patients improved the quality of life significantly as opposed to the baseline after 12 months. And they were comparable to a control group of patients. But again, we didn't control with a comparable patient group, so it was non-randomized. This is the work from Von Boven, as I'm sure you're very well acquainted with. 30 patients, 43% of the patients had failed transvenous PVI. Most of the patients had paroxysmal AF, 27 persistent, and quite few permanent AF. Comparable results, 77% of the patients were free from AF at follow-up of 11 months. Again, non-randomized, quality of life was not evaluated, and they only used 24-hour Holter monitoring. The next study is larger, and now we have introduced the box lesion approach. This is a study including over 100 patients. And as we can see, the efficacy rate was quite high, but it was higher than for the paroxysmal than for the persistent AF patients. The problem with this study is that the patients were still on antiarrhythmic drugs at follow-up. So 49% were on amiodarone, so you cannot really evaluate the result of this technique from this study. So let's see in general the overall results of the mini-invasive surgery for AF ablation with a surgical approach. This was presented 2 years ago by Marc Lamer. He included 28 studies. 96% were observational studies. It includes over 1,000 patients, and the studies have included between 14 and 114 patients. During 2004 and 2011. We can see that they were quite young, seemingly quite healthy patients. AF duration were still almost 8 years in some studies. Left atrial diameter was quite normal, in some cases quite enlarged. Many centers have referred their patients for this surgical approach if they have failed AF ablation. If we look at the type of AF, most of the patients had paroxysmal AF. Some had persistence, very few long-standing persistent and permanent AF. The success rate counted as free from AF off antiarrhythmic drug at 12 months was 65 to 92% for paroxysmal AF patients, 67 to 80% in the ones with persistent, and there were only 3 studies with quite few patients with long-standing persistent. One study included 81 patients, and they reported 80% success rate. If we look at the complications reported in this series, we see that there is a mortality with this procedure, 3 early deaths related to tearing of the appendage, cerebral infarction, and 1 unknown cause. Early complications occurred in 12%, ranging from 0 to 39%. It's a very high figure. And these were the early complications, sternotomy, most related to bleeding, of course, and some other kinds of complications related to the procedure as a whole. So, of course, it's important to know when we look at these reviews, how they have defined success rate and how they have performed their procedures. So in the guidelines, definitions were introduced, and they recommended that for evaluation of efficacy, patients should be included with atrial flutter and atrial tachycardia. They should be off antiarrhythmic drugs, a 3-month blanking period, and the follow-up should be 12 months. For long term, they should be followed at least for 36 months with the same requirements. A recurrent AF, atrial flutter, atrial tachycardia is defined as one that is of a duration of 30 seconds or more. For surgical PVIs, entrance and or exit block should be demonstrated, and linear lesions should be checked for completeness. So these were the recommendations in the AF ablation guidelines. So if we introduce these requirements into this series of patients, there were only 6 studies left, actually. And if we look at the study by Wang, I would have excluded this one because this was a randomized trial evaluating the effect of AC inhibitors, and they were not very well defining how the patients were followed with Holter monitorings. Anyhow, only 6 papers clearly defined the primary efficacy, and follow-up was 93% complete, and the success rate in these trials were between 51 and 86%. Among these reported reviews, we did not yet publish our results of the box lesion, so I thought I would present it here to you now. We have included 60 patients undergoing pulmonary vein isolation and a box lesion. That means a roof line and an inferior line and an aortic trigonum line. These were patients with mainly long-standing persistent, 80% were long-standing, 10% persistent, and 10% paroxysmal, and these were the ones that have failed previous catheter ablation. The mean AF history was 8.5 years. What we do during this kind of procedure is that we have an electrophysiological person and also a physician checking for line integrity. After the pulmonary veins have been isolated on the right side, we check for PV isolation in both and in the middle. And we do the line to the aortic trigonum, and after that we pace at A and record from B1 and B2. So we check the line integrity here to see that we have conduction block. And of course, this is not very easy because you can have seemingly conduction block. That is, you may have the first activation from the far electrode from the line, the B2, but that may be related to a very slow conduction to the B1. So, we have to define 10 milliseconds we require for conduction block, but we are well aware of that it still could be sort of false negative. The indications we use for left appendage exclusion if the patient has a CHAT score 2 or more, and if there is not a significant risk, which is judged by the surgeon with a TE and the morphology and how if there is a wide base of the appendage and if there is a thin wall. So in this, among these 60 patients, the appendage was excluded in 27%, only in 16 patients. Patients were followed for 1, 3, 6, and 12 months with 7-day Holter. They were evaluated with symptom quality, severity of symptoms, quality of life, SF-36. And as a result, all patients converted to sinus rhythm during the surgery. The 12 months follow-up show that 93% were free from AF, but 10 patients suffered from left atrial reentran tachycardias, 14% required treatment, that is left atrial ablation, which has been quite tough sometimes. 86% of long-standing persistent has maintained sinus rhythm, so I think it's quite good results still. and the symptom severity score improved significantly. But the problem, I think, has been these left atrial tachycardias, which are more difficult for the patient and more difficult for us to treat than AF ablation. The procedure times have been 317 minutes, ranging between 249, 420 minutes. Number of applications has been on the left side 6 and on the right side 7. But in the later patient series, we routinely give 6 or 7 because we think it's needed. Hospital stay in mean 10 days. The serious adverse events have included 6 bleedings, 3 of which required stenotomy, 2 ischemic strokes. One was related to the fact that a patient missed the TEE the day before. It was not the usual physician in the ward, so he didn't check that the patient had undergone a TE, and at the operating theater we could see that the patient had a thrombus in that auricle after the right side had been done. The second patient had this stroke when the anticoagulation therapy postoperatively was switched from when the low molecular heparin was stopped, when the warfarin INR value was reached 2. So that was a mistake also to stop it too early. Now we only stop after the INR have reached 2.5 or something like that. Then also we have now also, let's look at the hybrid AF ablation procedures. This is Laurent's work. I think it's a very nice work, including 78 consecutive patients, included between 2009 and 2012, and this work was published last year. They included 29 paroxysmal, 34 persistent, and 15 long-standing persistent AF patients, and these are the different techniques used. All patients had pulmonary vein isolation, of course, and box lesions were performed in 83% of the patients, but I think it's somewhat difficult to evaluate the results because there have been some different approaches, and so it's difficult to really know the value of the procedure if you don't stick to the same technique the whole time. The outcome is presented here. You can see the overall outcome, 87% free of AF atrial tachycardia at 12 months follow-up, 87%. For the long-standing persistent, 100%, 15 patients, although persistent AF 82%, paroxysmal 76%. So if we look also at the value of the transvenous approach simultaneously with the epicardial approach, 36% of the box lesions needed touch-up. So this is an example how you can falsely probably interpret it as a complete block in the box, but that you can only check when you put a catheter inside the heart. Finally, this last review of different techniques, this one was published just recently this year. It compares the endocardial Cox-Maze approach in 2 studies, 145 patients, epicardial surgical ablation, 26 sites, 1,300 patients, hybrid surgical ablation, 9 centers, 350 patients. And as we can see, the type of energy used was cryo in the Cox-Maze procedure and RF in the later 2. And if we look at the kind of lesion set performed, we had biatrial ablation in the Cox-Maze and PV isolation and box lesion in the majority of the epicardial and hybrid procedures. In this review, they excluded patients that were followed shorter than 6 months, and they excluded, of course, the concomitant cardiac surgery procedures. And all had to be published in peer-reviewed papers. The types of AF that the patients had were paroxysmal in almost 50%, long-standing persistent and permanent in 1/3 of the patients. The success rate at 12 months were higher with a Cox-Maze procedure, 87%, epicardial approach 72%, the hybrid group 71%, and these were all off antiarrhythmic drugs. If we look at the results in boxes, we can see that the dark blue boxes is the Cox-Maze, and the red and light blue is the epicardial and hybrid procedure. And one can speculate why the blue boxes had a superior outcome. I think it might be related to the fact that the patients were on pump, so there is no cooling effect and more reliable transmural lesions, but again, not the same control group. So again, very difficult to know if there is a real difference or not. If we look at the complications, the mortality seemed higher here in the two procedures, but again, very low figures. Pacemaker dependency higher in the Cox-Maze group, of course, because you were ablating on the right side for some reason, I don't know. Stenotomy, 2.4 and 2.5%, and bleeding related to the surgery, 1%, 1.5, and 2%. So Cox-Maze seemed to have lower complication rates except for the pacemaker dependency. So my conclusions based on these results is whether hybrid epicardial surgical AF ablation procedures can maintain sinus rhythm and have a beneficial impact on symptoms, quality of life, rhythm in long term. Has not been tested in adequately randomized trials, so we need randomized trials. There is one ongoing or going to start. Most of these results are from various high volume and skilled centers, so it's still unclear whether the same results would be presented if there was less experienced centers that would start with the epicardial AF ablation approach. So I think we need registries. So there's also one registry planned, TFR, which will be run by the ERA and EORP management. Thank you.
Thank you for this excellent overview. Does somebody have a question? I was wondering, so we have now these different ablation options. What is your personal strategy if you have a patient in front of you in the outpatient clinic?
From scratch, you mean? I think the new cryoballoon is the most attractive strategy. You have contiguous PV isolation, and you have quite broad lesions. So I think you have a very antrum. You get a very antrum ablation for these patients. So that's what we start off with. So we stopped
every patient.
In every patient, in persistent patients, in paroxysmal patients. We see no difference actually, okay, except for the long-standing, which we have not evaluated.
Okay. Carina, thank you very much for an excellent overview. My question is, that might be a question of also the surgeons in the audience. How do you explain that you do this epicardial approach where you isolate and you also do the trigone line, that most of those, almost all of the patients were in atrial fibrillation at the end of the procedure. So you really did the central piece, so that's isolating the veins. You didn't do a box, right?
Yes, we did
a box. Okay, you do a box, and then you do the trigone, and still these patients are in AF. And then you have to shock them to sinus rhythm. And then in the long run, over 90% is doing well. What's your favorite explanation for that? Because the arrhythmia is still there, the mechanisms are still there.
Yeah, you have got rid of the trigger, but you have the substrate still, so you have to remodel.
So, and how do you approach that? Do you keep them on antiarrhythmic drugs for some time?
I think perhaps the best way that we do now is actually to try to convert the patient before and put them on amiodarone a month or so before the procedure, whatever, if it's a long-standing persistent. And if that is not possible, to give them some drugs so that they can keep AF, because it's our experience that if you have the Cox-Maze patients, they had postoperative atrial fibrillation, 35% of them had it. So obviously, even though they did suffer from that for 1 month, maybe even, they were free from AF.
Afterwards, yeah. So there are two aspects.
Afterwards.
One is the reverse remodeling, and the second point, especially the Cox,
Yeah,
the cut and sew
yeah.
was the arrhythmogenicity of the
Yeah,
lesions, probably. But
Yeah.
Dr. Damiano, you want to add?
Yeah, I'll add just a little something. Excellent review, and congratulations on your good results. So I would say when you report your results, you know, atrial tachycardia by the consensus statement you showed is a failure, so that should be reflected as a failure, not as a success of lack of AF, because it's really lack of any atrial tachyarrhythmias. And, you know, I think that's a more consistent way to report it. But I would say the postoperative AFib is totally different, and we have a long interest in that and have studied that. And probably the most arrhythmogenic thing you can do to cause postoperative AFib, which is a completely different mechanism. I think too often we lump all the AFib together. It's totally different.
Yeah.
So that's all inflammatory, and probably the most inflammatory thing you can do, and it's probably true with catheter ablation, that AFib you get days later. I will say after a maze, it's unheard of not to be out of AFib at the end of the surgery, but we never have that. We get the AFib, the postoperative AFib usually occurs at 2 or 3 days when inflammation's at its peak, and there's really no way to prevent that. You know, steroids can prevent it, but it also impairs wound healing, so we really don't recommend it. But I think it's a different story.
That's true. Yeah.
And I wouldn't use that. I think it's different than if you're doing an epicardial procedure and you can't get them out of AFib. I think that's a different. But I do agree there probably is some type of remodeling. On your study, how many patients were off antiarrhythmic drugs? And could you comment, it seemed like you had a pretty high complication rate with conversion to sternotomies and those type of issues. Has that gotten better as you've
Well,
gotten
that was
more
actually the
experience?
first 15 patients, so we suffered from that, and well, that happens. I'm a rift on the pulmonary vein and the appendage, and yeah. But not during the past years. I just want to add, I think it's important that you mentioned the atrial tachycardias. Of course, they have to be counted as failures as well, but it's important that we get to know in the different works how many patients actually have atrial fibrillation afterwards. Because if you isolate and you're free from AF, because the atrial tachycardias is a consequence maybe of the linear lesions. So of note, doing the box lesion, you have extremely high freedom from atrial fibrillation, not touching the right side.
Just one question.
Then another question.
Good presentation. I've always wondered, we do these procedures also with Mark in our center, with Professor Mark. And I've seen these series many times, paroxysmal atrial fibrillation being presented as. Now, I think this is, well, these procedures tend to be relatively gruesome also for the patient in the revalidation, rehabilitation phase. So how do you convince a patient with paroxysmal atrial fibrillation, who has a very high chance of getting out of his AFib with a simple cry balloon? We both agree on the same things in this way to undergo this.
To undergo what?
Well, an epicardial ablation.
Ah.
Yeah, I mean, I find this. I mean, I don't know how you can convince a patient with paroxysmal atrial fibrillation.
No, I don't. Not as a first procedure. No.
But there are series which show it as a first procedure. So I would like to know your comment on that.
No, I think that is the wrong way. I think you should offer patients with paroxysmal AF first procedures with a cryoballoon, definitely. If you fail, despite maybe 2 or 3 times, whatever, if you see that the patient improve after the procedure, then you know if you isolate the vein, then you will have a good outcome. So if they recur, reconduction, you should offer them the same procedure again. Sometimes you cannot isolate endocardially. We have referred them for epicardial, and they have been fine. So that's all right, but not as a primary procedure.
Okay, no, because there are studies showing it as primary procedure.
Yeah.
Thank you.